Hello, everyone, and very warm welcome to today's edition of Podcast. Today is Tuesday, March 23rd, 2021. I am Rifat Manan, and I am remotely joined by my good friend Emilio Madrigal, who is in Boston right now. Today, we are delighted to welcome Dr. Lin Hoang, who is a clinical assistant professor at University of British Columbia in Canada, and she is going to deliver the 11th lecture in the GYN Pathology lecture series. And the title of today's talk will be Squamous Neoplasia of the Vulva, from Novice to Nuance. As always, please feel free to post your questions and comments on YouTube and Facebook chat windows, and Dr. Hoang will answer them towards the end of the session. Thank you so much, Dr. Hoang, for joining us today, and over to you now.
Thanks, Rafat. Thanks for the invitation to speak. As mentioned, I'm going to talk to you about squamous neoplasia of the vulva. So this is a sort of a rare topic in the gynecologic tract. And there's a saying that we have in Canada is that if you're a trainee, you're essentially responsible for knowing sort of the more common things, horses, so we call it horses and zebras. So horses being very common entities and zebras being sort of very rare entities. And I think when it comes to squamous neoplasia of the vulva, you're also responsible for knowing some very odd, even rarer things, and such as Zorses, which you may not have heard of prior to today. But we're going to try to focus on the most common entities, but we are going to try to throw in some entities that you may not have heard of. So for today, we're going to go over vulvar squamous cell carcinoma and just sort of give you the basics. And then we're going to go over HPV-associated squamous lesions of the vulva, HPV-independent lesions of the vulva, and then we are going to go over some practical points and some paradigm shifts. So it is cherry blossom season in Vancouver, so that's why you're going to see a lot of cherry blossoms throughout the presentation. So we're going to start with an overview of squamous cell carcinoma of the vulva. So what is vulvar cancer? So vulvar cancer is a malignancy that affects the skin and structures that surround the female external lower genital tract. So that encompasses the labia majora, the labia minora, the clitoris, and the accessory glands. It is a rare cancer as defined by the NCI, and it has quite a low incidence, 2.6 over 100,000, with a lifetime risk of 0.1%. So as a rare cancer, they're pretty difficult to prevent, diagnose, and treat than more common cancers because there isn't a lot of attention paid to patients with vulvar cancer. It's harder to get funding, but we all know that it can be quite a morbid disease for our patients associated with quite high mortality, particularly with high stage disease and with recurrent disease. So there are lots of types of vulvar cancer that you'll be tasked with knowing. For this presentation, we're only really going to focus on squamous neoplasia. And that really makes up 90% of all tumors in the vulva. So I think the first broad thing to know about vulvar squamous cell carcinoma is that there are two different pathways to get from normal squamous epidermis and mucosa into squamous dysplasia and then invasive squamous cell carcinoma. And the first category is through HPV infection. And then a second pathway or category is through HPV independence, so meaning that it doesn't have anything to do with HPV. So I think this is going to be quite a bit of a detailed slide, but I think, especially if you're training, it's worthwhile knowing the pathways to get to invasive squamous cell carcinoma in a little bit more detail. So we mentioned that there is one pathway that is driven through HPV infection, and this leads to an in situ lesion, commonly known as UVIN, usual type VAN, also known as Hcell. And this occurs typically in younger women in their 20s to 40s. It is usually a multifocal and multicentric disease, and they're associated with certain risk factors, of course, like smoking, immunosuppression, certain sexual practices. And then there's a different pathway, as I mentioned to you in the previous slide, that is not driven by HPV. It usually occurs in older women who are usually in their 60s to 80s. It's more often a unifocal and unicentric disease, and it commonly occurs in the context of lichen sclerosis and chronic inflammation, irritation, and ischemic stress. And the precursor in this HPV independent pathway is known as differentiated VIN. So in terms of progression to invasive squamous cell carcinoma, the HPV associated pathway tends to occur quite slowly. Very few of them actually end up progressing to squamous cell carcinoma. And when they do, it usually takes about 6 or 7 years to progress. And the prognosis, when they do become invasive squamous cell carcinoma, tends to be very good. Under the microscope, they more often look warty or basaloid in morphology. For HPV-independent squamous cell carcinomas, the progression to invasive squamous cell carcinoma is quite fast. So the majority will progress to invasion, and it usually occurs over 1 to 2 years. And the prognosis for these squamous cell carcinomas is generally quite poor. They more often have keratinizing morphology, but as you'll see later on, this is not always the case. And then there's this sort of third pathway to invasive squamous cell carcinoma that we don't know a lot about. It's an HPV-independent pathway that leads to a precursor lesion that is known as VAD or devil. So it does have some very interesting names. And it has an intermediate prognosis. So they're thought to give rise to verrucous carcinomas, which are supposed to be very well differentiated and have a very good prognosis. But there is some evidence to suggest that this precursor lesion may also give rise to conventional P53 mutated squamous cell carcinoma. In this third pathway, these tumors tend not to be associated with P53 mutations. They're more often associated with PIK3CA and HRAS mutations. So why is this important? So why is it important to know that vulvar squamous cell carcinomas can be HPV associated or they can be HPV independent? Well, the reason is because multiple studies from multiple institutions have shown that HPV associated or HPV driven tumors tend to have a much better prognosis compared to those that are not associated with HPV. And this is generally a trend that you see across multiple tumor sites that are prone to HPV infection. So this occurs in tumors of the cervix and in the head and neck region. So it's not surprising that tumors of the vulva would exhibit this same dichotomization of prognosis. So in terms of clinical features, to break it down a little bit more, these HPV-associated squamous cell carcinomas tend to occur in patients of younger ages. They tend to be lower FIGO stages. They're less likely to have positive margins. They're less likely to have local recurrences and lymph node mets, and they tend to be more sensitive or responsive to chemoradiation. So you can imagine with all of these different factors, why these HPV-associated tumors tend to do better. So there is some recent data. So I did show you one of the slides that showed a third pathway. So if you break down the third pathway, which is HPV negative, but P53 wild type, they tend to have intermediate overall survival and progression-free survival, which is why maybe some of the newer literature will break this down into 3 different pathways as opposed to just having 2. So with all of that being said, and highlighting just how important the dichotomization by squamous cell carcinomas by HPV status, how important it is, the most recent edition of the WHO has actually gotten away from characterizing squamous cell carcinomas by just morphology. So you'll read in the 4th edition of the WHO that they're breaking down into keratinizing squamous cell carcinomas, non-keratinizing, and basaloid and warty and verrucous. But we now know, like at many other tumor sites, that morphology is not as important as underlying etiology. So instead of sort of putting them into these morphologic categories, the new edition of the WHO will separate squamous cell carcinomas into HPV associated and HPV independent. So then how do you tell an HPV-associated tumor from an HPV-independent tumor? So as you would expect, you can sometimes go by morphology. These HPV-associated tumors are more often basaloid or more often warty in appearance, and you can see adjacent Hcell. But as we're moving more towards monodizing sort of our prognostication and classification systems, it is recommended that P16 is used, and this will be endorsed in the upcoming ICCR guidelines. And the reason why that recommendation is made is because there's actually quite a bit of substantial overlap. So in terms of morphology, so basaloid or warty morphology can be seen in 20 to 40% of HPV-independent tumors, and the same thing with the in situ lesions. So there's quite a bit of morphologic overlap that you might end up misclassifying an invasive squamous cell carcinoma if you're not using P16. And which test are you going to use to look for HPV? You can use P16 or you can use HPV PCR-ish, but generally P16 has shown higher performance because it is able to pick up some of the false negatives that you'll get with these latter methodologies. So Dr. Orty actually has a nice summary of this on the companion median and USCAP. So it's also a nice talk just to tune into. So just to reiterate the types of morphologies that you'll see, so in HPV-associated tumors, they're more often sort of this basaloid or blue-looking tumor, and HPV-independent tumors tend to be more pink and keratinizing. But again, as I mentioned, you can't always tell the difference by morphology, and I'll tell you that both of these tumors that I'm showing you here are actually both P16 and HPV positive. And just a primer on P16 and HPVH. So for P16 to be called positive, it really has to show this sort of diffuse, strong block-like staining. And this is just an example of high-risk HPV in situ hybridization. So this is ACD RNA scope, and it's sort of this punctate or granular staining that is mostly confined to the nuclei. Some people have asked me before if you see a lot of cytoplasmic staining, but I actually haven't seen much, particularly with this method. So we're going to move on to HPV-associated squamous neoplasias. So I think as a learner, it can be quite difficult because depending on what you read, you're going to see lots of different terminologies used to describe HPV-associated squamous lesions. And just know that in the most recent edition of the WHO, there really is an attempt to consolidate this terminology. So all of these lesions not fall under the HPV-associated category, and they can be broken down into Elsil and Hcell. And this really follows the last guideline. So this was published in 2012, which to me seems like yesterday, but it's actually been quite a long time since this has been published. And really the last project was a guideline that was meant to unify terminology for HPV-associated lesions in the lower anogenital tract. So instead of having this sort of continuum where you would see VIN 1, 2, and 3, that would suggest that 1 turned into 2, which turned into 3. We knew that by biology, this would actually be separated into Elsil, which was associated with low-risk HPV infection, and Hcell, which is associated with high-risk HPV infection. And each of those entities certainly have different clinical ramifications. So we're basically following the Bethesda criteria, and because some of our surgeons or clinicians will be traditionalists, you're still allowed to use the in terminology, but you're supposed to actually put it into brackets. So if you're going to say, you'll make a diagnosis of Hcell bracket VIN 3. So this is an example of Elsil. So Elsil is driven by low-risk HPV infection, and it's essentially a benign entity, and it's self-limited. And there are a proportion of patients that will regress. So Elsil in the vulva is a little bit different than Elsil in the cervix. They're more often exophytic lesions or more condylomatous lesions than they are flat lesions that you would see in the cervix. But they're entities that you generally see good coilocytic atypia. So here you can see, there's multiple papillary fragments, and you can see the coilocytic atypia sort of accentuated within the divots or the grooves of these papillary fragments. Sometimes it can be quite difficult. I'd say sometimes, you get these sort of lesions that someone doesn't know if it's a fibroepithelial polyp or it's a condyloma, and that's a very common question. And you really have to try to sort of look for coilocytic atypia, which can actually be quite subtle in some cases. But again, you kind of want to look for those grooves or those divots. The other way to sort of think about it is, the overall contour of a condyloma is kind of like your fist, right? Like it has little grooves and little divots. So if you sort of look in the knuckles, that is where you're going to find these cytologic changes. So in order to call something Elsil, so it should be, acanthotic or papillomatous or flat. And again, it's more often the former. It should exhibit coilocytic atypia, so perinuclear clearing, enlarged nuclei, hyperchromatic or racinoid nuclei, and sometimes with binucleation. So you're really looking for these sort of irregularly shaped large nuclei that don't mature towards the surface. There tend to be mitotic figures and apoptotic debris, and it can have perikeratosis, hyperkeratosis, and acanthosis. So this is just an example of what P16 would look like. So because this is driven by low-risk HPV infection, P16 is going to be negative. And what that means is you're essentially going to get no staining, or you're going to get very patchy, blotchy sort of staining. I actually get some consults, and I wouldn't say few consults about this issue. And, people sort of panic when they see a blush of P16 staining, and they think it's supposed to be read as positive, but it's actually negative. And I'll say that I actually like seeing the blush of staining because it tells me that the P16 actually worked. So I actually find it reassuring to see a little bit of a blush. So this is a very common question that comes up is, how do you tell the difference between a condyloma and a seborrheic keratosis? So this is actually a really challenging question. And there are some entities that really, really look like seborrheic keratoses in the vulva. They've got these keratin horns, and it can be really difficult to tell the difference. But there are some series that have shown that in the genital area, if you're thinking about a seborrheic keratosis, you have to look really hard for a condyloma, because 2/3 of these lesions will actually be associated with low-risk HPV infection. And some things that will help you is broadly evenly distributed acanthosis, coilocytosis, of course, fascicular arrangement of keratinocytes with a little bit sort of more whorled, and the absence of horn cysts will favor a diagnosis of a condyloma. At the end of the day, it may not be incredibly clinically important, since they're both benign, self-limited entities. And there's a trick that I actually hold up my sleeve that I like using, and that's Ki-67. And the way that I usually think about this, and I apologize, I don't have a picture of it because I couldn't find it in my archives. But when you think about normal squamous epithelium and maturation, Ki-67 should really be strongest at the base. And as those keratinocytes mature, they tend to sort of mature and slough off at the surface. And so Ki-67 usually goes down. So with condylomas actually different, because as the keratinocytes mature, the HPV infection actually has more opportunity to hijack the cell cycle and actually proliferate. So the Ki-67 is actually higher in the top. So if you sort of see a top heavy Ki-67 pattern, particularly that's accentuated within those knuckles or grooves that I mentioned earlier, that's a good indication that this is a condyloma and not just a seborrheic keratosis. So we're going to move on to Hcell. So Hcell is associated with high-risk HPV infection, and the cumulative 10-year risk of squamous cell carcinoma is about 10%. It's about 5 to 10%, depending on what you read. I think this is an entity that most, even junior pathologists will be able to pick out. It looks really, really blue or really dark on low power. It can be sort of verrucous or warty, meaning, sort of spiky in appearance, or it can be flat like this and flat and dark blue. So in terms of cytologic features, what are you looking for? So a loss of maturation, being basaloid in appearance. So instead of looking pinker on the top and bluer at the bottom, you sort of have this blueness throughout the epithelium. The nuclei are hyperchromatic with high NC ratios, meaning they have really little pink cytoplasm. Mitotic figures, which generally you can see higher up in the epithelium, and apoptotic debris. They can have pleomorphism and coralicytic atypia, and if they do, it should not discourage you from the diagnosis of Hcell. So this is based off of the last guidelines. So, how much P16 do you need to actually cause something positive? So most of the time, you're going to get strong block-like staining for P16 throughout the full thickness of the epithelium, and that's consistent with HPV presence or high-risk HPV presence. But in general, you don't actually have to have full thickness. And the last guidelines will actually endorse this, that you need just staining in at least the lower 1/3 of the epithelial thickness. And that's enough to cause something HPV positive. You just have to make sure that it's strong and continuous, at least that lower 1/3. So there's another trick that I like to hold up my sleeve, and it's this P53 pattern in HPV-associated lesions. And you'll hear more and more about this pattern, at least nowadays. So these HPV-associated lesions tend to have a basal sparing pattern, meaning that P53 is completely absent in the basal layer, and you can have strong staining for P53 in the parabasal layers. We'll talk about this a little bit more. So I actually find this a very helpful pattern, particularly if I get a false negative P16 stain, I go to P53, just because it's a lot more accessible than looking for HPV in situ hybridization or HPV PCR. So classically, these P53 patterns are called mid-epithelial with basal sparing. And what that means is that very basal layer is completely negative for P53 staining. And the adjacent parabasal layers tend to be very, very strong. So if you're actually not looking for that very basal layer, you can actually be misconstrued and think that this is a missense mutational pattern when it's actually not. There are other things to keep in mind. This basal sparing pattern actually has some variance. So sometimes you get absence of staining not only in that very bottom layer, but you can have absence of staining in a proportion of the parabasal layers that can almost be full thickness, to the point where it almost looks null. So if you see sort of null-like staining in something that you would consider HPV positive, you just have to be careful, because that's actually not a mutational pattern. That's just a P53 pattern in an HPV-associated lesion. And how does this all make sense? So this actually goes back to HPV pathogenesis. So E6 binds to, or HPV oncoprotein E6 binds to P53 and actually gets rid of it. So it mediates ubiquitin-mediated degradation of P53. So those cells infected by HPV are not going to express P53. And if you actually correlate these staining patterns with HPV in situ hybridization, you can see that the cells that are positive for HPV in situ hybridization are actually negative or show no staining for P53. So it's a pretty nice correlation. So we're actually going to move on now to HPV independent squamous neoplasia. This is probably the harder topic to wrap your head around. And again, part of it is sort of our lack of understanding and being consistent about the terminology of these lesions. And again, if you go back into the older literature, you're going to get lots of different names that have been used to describe this type of neoplasia. And just to reiterate that in the most recent edition of the WHO, these are not all captured under the umbrella of HPV Independent Vin, and it captures the categories divan, devil, and bad. So we're going to start with divan, so differentiated VIN. So this is a slide that I've shown many times because I think it's fairly convincing for differentiated VIN. You've got sort of long, irregular, anastomosing rete ridges with quite conspicuous basal atypia. And the things that you're supposed to look for in differentiated VIN, as I mentioned, is you're supposed to have, pretty marked basal atypia, hyperchromasia. You can have karyomegaly, nucleoli, atypical mitosis, dyskeratosis, and acanthosis with elongated rete ridges, which I showed you in the previous slide. But I think the reality is, even though this is what you were supposed to see and differentiated VIN, the reality is those features are a lot more subtle than what you would recognize. And these are some lesions that we actually ended up sequencing. And you can ask yourself when you're looking at these slides whether or not you would call this differentiated VIN or you would just call these benign entities. And there's quite a bit of superimposed inflammation in some of them, and some of them are not as thick as you might expect. And the reality is when we actually ended up sequencing all of these lesions, they were all positive for P53 mutations. So these are all representative of differentiated VIN. So just note that the morphology is a lot wider than you expect it to be. And just because you see superimposed inflammation, you shouldn't just negate the diagnosis or dismiss the cytologic atypia to being reactive. And just because it's thin doesn't mean that it can't be divan. So that brings a bit of nuance to this talk. Well, one, I would say I've probably scared most of the residents in my program because they think they throw P53 on everything now because they're so scared of it. So there's a bit of like a Hoang effect or something. But anyways, but it does kind of bring into the question, well, what is enough to call differentiated VIN? So what are the minimal histologic criteria? And that's, very difficult because I mentioned to you, they can be very, very subtle. So the way I think of it is, if there is a P53 mutational pattern by immunohistochemistry, and there are enough suspicious features that cause me to do the P53, then I'm going to call it divan. And then I think the natural question that people ask is, well, if you're calling everything with a P53 mutation divan, so what is the lower limit of your diagnostic threshold? And this one is really tricky. So, I think a lot of people will say if you have some features of divan or full features of divan, especially if it's adjacent to an SCC already, you're just going to call it divan. And people are not really going to argue with that. The problem comes when you have some features of divan, or maybe even atypical lichen sclerosis or hypertrophic lichen sclerosis. Do you call that divan? I would say if you have a P53 mutational pattern, I would. And of course, the trouble comes with, having P53 mutations, what you think looks like normal skin, or what has been described as, these sort of P53 signature lesions. Do you call that divan? And I wouldn't. So it's kind of like, the way I see it is sort of similar to the fallopian tube. If I had a P53 signature lesion in a fallopian tube, would I call that stick? I wouldn't call it a stick. I would just call it a P53 signature lesion. So the same thing in the vulva. I might mention it in my report, but I wouldn't actually call it divan. But those, I will say, are personal opinions of mine, having studied this disease. And I don't think that's written in a textbook anywhere that you'll find. So I want to give you a little bit of a primer on how to interpret P53. We actually end up looking at a bunch, I think 100 squamous cell carcinomas and adjacent in situ lesions, and working together with Jolling Bosse in the Netherlands, we were able to sort of merge our ideas and come up with this very nice grading scheme. So P53 immunohistochemistry can show two different wild type patterns. So you can have sort of patchy P53 staining in the basal layer and not much in the peribasal layers. And, when you look at them, you should always have stronger P53 at the base, and it always should sort of taper as you go towards the surface. Another wild type pattern is this mid-epithelial basal sparing pattern, which I showed you previously. And when you see this pattern, this is the HPV-associated pattern. So again, it's not a mutational pattern, it's just an HPV-associated pattern. So in terms of the mutant patterns, there are 4 different types. You can have very strong basal-only overexpression. You can have parabasal and diffuse overexpression. Absent or null staining, for which you, of course, you always have to have an internal control, and cytoplasmic staining, which again, I think you should always have an internal control that shows nuclear P53. Otherwise, you run into the risk of, a stain mix-up or something else in the lab. So the same patterns that you see in the in situ lesions, you can apply to the invasive squamous cell carcinomas. And why would you do this? And this is for prognostication, because we know that these SCCs with P53 mutations tend to do worse. So for those of you who don't have access to this article, I've just put in this table for you to look at. So here are just some examples. So this is a wild type P53 pattern, so sort of patchy heterogeneous staining at the base that sort of tapers towards the surface or centrally. This is a wild type pattern, but it's actually a strong wild type pattern. So this is just to emphasize that you have to know your P53. I know our P53 in our lab really well. So I know that this is just a strong expressing, but still a wild type pattern. This is a mutant pattern. So this is sort of parabasal diffuse overexpression. This is another positive or mutational P53 pattern. So this is the basal overexpression pattern. This is null type staining, and this is cytoplasmic staining. So I actually gave a talk and sort of tutorial on how to interpret P53 in vulvar squamous cell carcinomas for ISCHIP. So they have an educational website, and I'm sure it's still on there. So if you want like a more detailed description and some tricks of the trade, I would say, for P53, you can listen to this talk. I think it's probably about 40 minutes long. The things to keep in mind, especially, maybe not just for trainees, but things to keep in mind for everyone, is that there's always a morphologic mimic, right? So the way I kind of think about this is if I see too much pink in a dysplastic squamous lesion, I'm thinking about divan. If I see too much blue, I'm thinking about uvan or Hcell. And for these differentiated VAN, they're P16 negative, they're P53 mutant, and then for Hcell, they're P16 positive, and they show this mid-epithelial or basal staining pattern. But there are exceptions. So there is Hcell with superimposed lichen simplex chronicus. So this was described by Jacqueline Watkins and Christopher Crum. And so this is P16 positive because it's an HPV-associated lesion, and it shows this basal sparing pattern. So you have to be careful with these particular lesions. And the same thing, there is a variant of divan that is actually very blue. And this is Basiloid divan, and this was initially ascribed by Dr. Orty. So it's P16 negative, as you would expect, and they tend to have P53 mutational patterns. So just be aware that for divan and Hcell, there are morphologic mimics, but there are some biomarkers that will save you or rescue you from falling down, the wrong rabbit hole. So this is just an example of basaloid divan. So something that looks very blue and basaloid in appearance, but this is actually differentiated VIN. It's P16 negative, and P53 shows a mutational pattern. And this is an example of Hcell with superimposed lichen simplex chronicus. So, it looks a lot more pink than you would expect for Hcell. There is some sort of scattered cytologic atypia, but lots of pinkness, hyperkeratosis, and parakeratosis. And actually, P16 is positive in this lesion. So this is in keeping with high-risk HPV infection. There is a basal sparing pattern, which is also very helpful. And in this case, there's actually Candida. So there's a reason why this patient has superimposed lichen simplex chronicus. So just something to keep in the back of your mind that, there is some morphologic overlap between the two. So we've talked a little bit about differentiated VIN, and this again falls under the WHO HPV independent VIN category. And we're just going to say a few things about devil and vad, which really have quite neat names, I would say. You know, they're I don't know how people are so imaginative and come up with these names. So it's pretty amazing. So DEVIL stands for differentiated exophytic vulvar intraepithelial lesion, and VAD stands for vulvar acanthosis with altered differentiation. So what can we say about both of these lesions? So this is an example of DEVIL, and I will mention to you that I've actually, you know, we have at our site microdissected these tumors and actually sequenced them, so we know they have certain corresponding mutations. So if you're not a believer, these have actually been genomically characterized. So this is an example of DEVIL. And the way I sort of think of DEVIL is it's a lesion that's hyperkeratotic and acanthotic, and they tend to have these spikes or sort of verruciform architecture, something that I would think looks like a wart. But when you go on high power, there's no cytologic features to suggest an HPV infection. And that's sort of the way that I think about DEVIL. They can be quite thick or they can be quite thin. And the trick about DEVIL and VAD is they're not going to have that cytologic atypia that you see in divan. And of course, that's probably related to the fact that they don't actually have P53 mutations. So this is actually an incredibly difficult diagnosis. So things that you're supposed to look for, so exophytic or verruciform growth. So again, sort of this warty looking appearance, acanthosis with hyperkeratosis, and it's usually a retained granular layer. They have minimal nuclear atypia, and importantly, they don't have features of HPV infection. And this is an example of VAD, which I think, you know, looking at these cases probably fall on this morphologic continuum of DEVIL. They're probably two forms of the same thing. And the way I usually think about these is they tend to be sort of thick lesions. And instead of being sort of verruciform, they're more often flat. And they're more often pale. So instead of being hypergranulotic, they're more often really hypogranulotic. So they're very pale and pink, and they will have some overlapping features. So when this was initially described, so they're comprised of a triad of acanthosis, plaque-like parakeratosis, loss of the granular layer. They lack cytologic atypia, so the same for divan, or for DEVIL. And they have this downward expansive growth and variable verruciform architecture, but they're more often flat. And again, they have an absence of quillocytic atypia. So as I mentioned previously, both DEVIL and VAD do not have P53 mutations. So they are actually P53 wild type lesions. And as you can see, they're sort of scattered, very weak heterogeneous staining in both of these lesions. So the thought is that VAD and DEVIL will both give rise to verrucous carcinoma. And what's verrucous carcinoma? So verrucous carcinoma is a well-differentiated squamous cell carcinoma that, you know, and when it does invade into the underlying tissue, it does so in this sort of pushing pattern. And there's some really neat names. People will describe it as having sort of elephant feet or like baggy trousers, like broad pushing fronts. But the trick about verrucous carcinoma is actually that they actually do really, really well. So they may be locally invasive, but they're not going to metastasize, or, you know, they're not going to be sort of aggressive tumors. But I'll say that a lot of people hesitate on making the diagnosis of verrucous carcinoma, and it is a very difficult diagnosis to make. So what can we say about DEVIL and VAD? So again, they likely represent entities on the same morphologic spectrum. They have mutations in PIK3CA, HRAS, BRAF, and NOTCH1, amongst other things. But the trick also, especially in the most recent literature, is that some of them can actually have P53 mutations. So even though we sort of think about divan as having P53 mutations and DEVIL and VAD not having P53 mutations, you know, some of the more recent literature shows that they actually can. And the other sort of funny thing about these lesions is they don't always spread to or become verrucous carcinomas. They can actually become your conventional P53 mutated squamous cell carcinoma. So this is a challenging diagnosis, and as you can imagine, just looking at the slides, there's only moderate inter-observer variability. They're more often confused with benign lesions like lichen simplex chronicus and verruca. The natural history we don't know a lot about, and that partly that comes from the fact that we're so bad at making the diagnosis in the first place. There are some sort of rare reports that show that the progression to invasive squamous cell carcinoma takes a very, very long time, about 2 to 6 years. But again, this is based on very, very limited data. So with all of that being said, looking back on all these slides, the majority of people are going to have a really, really hard time telling the morphologic differences between divan, devil, and vad. And so in recognition of this, the most recent edition of the WHO has sort of put this under this umbrella category of HPV independent VIN, for which you can then substratify into P53 mutant lesions and P53 wild type lesions. And, by doing this, you're sort of avoiding the morphologic stumbles, and you're avoiding the questions like, well, what if it looks like divan, but it's P53 wild type? Do I call that divan? And the same question for devil and vad. What if it looks like a devil or a vad, but it has a P53 mutation? Do I call that devil and vad, or do I call that divan? So by moving to this sort of more modern classification, we're avoiding those diagnostic or just morphology only pitfalls. So I'm going to just end off with some practice points and paradigm shifts that I think will be important to know moving forward in your careers at whatever stage that you are in. So in terms of tumors staging, there's again a TNM stage and a FIGO stage. And I just want to point out a couple things. So for depth of invasion, so the depth of invasion is classified from the epithelial stromal junction of the adjacent dermal papilla to the deepest point of invasion. So what that means is you're taking the most adjacent dermal papilla and you're measuring it from the deepest point of invasion, and that is your depth of invasion. And there's certainly been proposals to move away from that into sort of a modified way to measure depth of invasion. So instead of taking sort of that epithelial stromal junction of the nearest dermal papillae, that you would go from basically from the base of the rete and all the way down to the deepest point of invasion. And what this ends up doing is actually downstaging a lot of the tumors and preventing sort of over treatment for a lot of these tumors. So even though, this definitely has some advantages, because most of the literature is based on that old staging schematic, it hasn't changed. So just know that, even in the most recent edition of the ICCR and other guidelines, we're still going to use this first method. The other thing to know about is margin status. And, for a trainee, you're going to probably try to remember these numbers. And then for an attending or more seasoned staff, just know that these numbers are most likely to change moving forward as we adopt more molecular classifications into our daily practice. So what is the recommended margin clearance for squamous cell carcinomas? So most guidelines will recommend 1 to 2 centimeters of clearance, and that equates to 8 millimeters of histologic clearance after formalin fixation, and this has been adopted by most guidelines. The German guidelines are actually a little bit more conservative, based on a study that was published a couple years ago, saying that there really was no difference in outcomes between 3, 5, and 8 margins, so they go for more conservative 3 millimeter margins. It is mentioned that if there is a closer margin, particularly under 5 millimeters, that the patient may benefit from radiotherapy or re-excision. So radiotherapy if you just can't take out more tissue, and re-excision if you can. So the recommended clearance for in situ neoplasia is a little bit vague. A lot of these guidelines won't actually give you a measurement. FIGO will mention about 0.5 to 1 centimeters of margin clearance for in situ neoplasia. But, it hasn't really been widely endorsed by everybody per se. The other thing to mention is, there are limitations to margins assessment. but we will come to that in a little bit. So how do you actually measure margins? So this is a really practical guideline that came from the BAGP after one of their talks. So this is for Kim Corticus. So I like it because it has some really nice pictures. So how do you actually measure distance to margins? So there are different ways that you can measure a distance to margin. So to the epithelial surface, sort of tumor to the tissue edge. And generally you want to go for the closest margin distance, irrespective of whether it's actually on the epithelial surface or not. What about curled tissue? So very often you can get sort of curled, rugged or ragged tissue. And instead of sort of drawing a wavy line to get your distance, you just want to draw a straight line. So that ensures consistency for everybody. What about a polypoid or exophytic tumor? Well, yes, you know, shortest distance is technically here to here, but you should go through tissue. So you always want to go through tissue from get your closest margin. And same thing here, you don't want to go sort of, you know, you don't want to be a purist and just go for the shortest margin. Again, you want to take the shortest margin that goes into tissue. So I will say the margin status is, there are a lot of deficits in the literature as to how to measure margins, excuse me, and what the significance is in the context of an HPV positive and HPV independent tumor. So all the margins are treated the same regardless of HPV status, but you should know that for these HPV associated tumors, if you actually do P53 immunohistochemistry, it actually changes the margin status from negative to positive in 1/3 of cases. And why it does that is it picks up unrecognized VIN or P53 signature-like lesions. And I've shown this previously. This is a whole section scan of a slide of, you know, probable DVIN, and you'll very often see a mutational P53 pattern in that DVIN adjacent lesions and in that normal sort of atypical lichen sclerosis lesion. So, you know, we do see this sort of P53 signature lesions in about 4% of cases. The other thing to mention before ending off here is grading. So grading is something that everyone is sort of very attached to. It's a traditional parameter that we use in pretty much every tumor type that we describe. But grading is no longer going to be a mandatory element in the ICCR. And that's partly because, you know, these basaloid SCCs, if you were to give them a grade, they're poorly differentiated. But we know they actually do really, you know, really well. And if you look at these keratinizing squamous cell carcinomas, you would probably say this is well differentiated. But we actually know that these HPV independent tumors that are more often keratinizing actually do a lot worse. So just going by grading alone without considering underlying etiology is not going to give us very good prognostic value. So going forward, it's not going to be a mandatory item. But I think, you know, I think some people will be attached to this. So that is it. That's all I have for you. So sorry for the whirlwind tour that I've given you, but things that we did talk about. So squamous cell carcinoma and stratification by HPV and P53 status. We talked about HPV associated lesions, HPV independent lesions, and then some practice points moving forward. I think that's it. Just wanted to thank the wonderful team that we have here in Vancouver, BC, Canada, and I'm happy to take any questions.
Thank you so much, Dr. Hoang. This was an excellent talk on such an important lesion. I have a few questions that I can see online. The first question is, what's the role of vaccine in these HPV-associated lesions?
Yeah, that's a really important question. So I think if you're living in a country with a nationwide vaccination program, then these HPV-associated lesions are going to go down. And there are several sizable studies from multiple nations that have shown that with HPV vaccination, these HPV-associated tumors, not only in the vulva, but in the cervix and the head and neck region, have actually gone down. And with that being said, that just means that all of us pathologists are probably going to face more and more HPV independent lesions. So they are something that all of us will have to get our heads around eventually.
Thank you. The next question is that devil same with well-differentiated squamous cell carcinoma or verrucous carcinoma?
Sorry, say that one more time. Are they the same?
Yeah, is the devil same as squamous cell carcinoma, well-differentiated, or verrucous carcinoma?
So the devil is an in situ lesion. So the devil is an in situ lesion, and then verrucous carcinoma and squamous cell carcinoma are invasive. Although I would say that a lot of people have a hard time telling the difference between devil, which is an in situ lesion, and verrucous carcinoma, because the pattern of invasion in verrucous carcinoma is pushing. And sometimes telling that pushing invasion from just an in situ lesion is difficult. But they are different.
Right. So the next question is about P53 staining pattern. So you have talked about cytoplasmic staining of P53. So how do you say that cytoplasmic staining is actually real and it's not, like artifactual or something?
Yeah, that's a very good question. The first time I saw cytoplasmic staining of P53, I thought it was a mix-up. I thought somebody mixed up P53 and P16, and I had to redo the stain. So the trick always with P53 is you always want to look at the background. So the background stromal cells, the background inflammatory cells will always have a little bit of P53 because it's a tumor suppressor. Every cell should have P53. So if you look for the background cells and it shows nuclear staining, then you know that your P53 worked. And that cytoplasmic staining is real. And the way to think about it is that all proteins are made in the cytoplasm, and then they get transported to wherever they are needed in the cell. So P53 is a DNA repair protein. So it'll be made in the cytoplasm, and then it's going to be transported into the nucleus in order to do its job, which is to repair DNA damage. And so this particular mutation, which is pretty rare, it's like 1% of all cases, actually disrupts the ability for P53 to be transported. And that is why you get a cytoplasmic stain.
Thank you, because I also found it very intriguing that, in GI world also we look at P53 and we always keep wondering that whether it is real, not real, because there is so much of ambiguity in the staining pattern as well. But my question, just from my curiosity, is that how do you correlate cytoplasmic P53 with prognosis or the stage of the lesion? Do you have any studies like that?
So in terms of the different staining patterns, we don't have any prognostic differences. So in terms of like overexpression versus null versus cytoplasmic, we don't actually have prognostic differences between the three of them. And I think part of that is just because the cytoplasmic staining is just so rare. Like you'll get it in like 1% of cases. So in terms of, is that particular stain different from the others? We haven't looked at it.
Right. Thank you. The next question is, a P16 immunostain, is it enough to classify a lesion as HPV dependent or HPV independent?
Yeah. So Dr. Orty has a really good series on this because he has a multinational study with over 1,000 cases. So in particular cases, so if you have a P16 positive tumor and an HPV positive tumor, that's easy. Like it's HPV associated. What if you have a P16 positive tumor, but the HPV testing is negative? What do you call that tumor? And looking at his study, the clinical behavior of a P16 positive tumor that's HPV negative by PCR or ISH is going to behave like an HPV positive tumor. So even though the HPV is negative, and the P16 is positive, it's enough to call it an HPV associated. And that's the same thing for what if you have like a P16 negative tumor, but that's HPV positive. Actually, prognostically, it seems to be more similar to these HPV negative tumors. So the weight or the precedence really goes towards P16. Yeah, it's a tricky one.
Right. Thank you again. So here is this next question. So which is about cytology. The question is, how effective is cytology in the Divin, Uvin, and Devil, etc.?
So cytology. So cytology for HPV associated lesions is quite good. For picking up Hcell, but they would be. I don't think anyone has ever studied it because we don't actually do swabs and cytology for vulva as we do for cervix. But I would imagine that it would be quite terrible. And the reason is because when you look at the atypia in something like Divan, it's always at the base. And so if you're going to swab, and get cytology from a vulva, you're going to get that superficial layer, which is not as atypical. So I just can't imagine it would be effective at all.
Right, thank you. There's another question about seborrheic keratosis. So it's more of a comment that says that seborrheic keratosis may not show a normal maturation of the squamous cells. So do you want to add anything to that?
Yeah, they tend not to. I find that the seborrheic keratoses, the cytology features kind of look uniform throughout, if that makes any sense. Whereas condylomas, they actually will have more atypia towards the surface. And again, that comes back to HPV infection and having more sort of virions at the surface. So that's kind of how I see the cytologic atypia. But again, I think it's going to be very, very challenging to tell the difference between the two. And at the end of the day, if you see I think the take-home message is, if you see a seborrheic keratosis in the vulva, just second guess yourself and make sure you look really carefully for features of condyloma.
Right. The next question is about condyloma. What is your practical practice guideline about using immunostains for grading vulvar lesions? For example, do you use P16 and Ki67 regularly, or do you rely more on morphology, or do you rely more on one stain over other? Just a practical guideline, as someone is asking. Or do you use in every case?
So practically speaking, if it's Hcell and the clinical fits, the cytology fits, I don't do anything. So I don't do the P16. Ki67 I find is never helpful unless it's in the context of a condyloma. But Ki67 is high in any proliferative lesions. That includes like psoriasis, spongitic dermatitis, like everything. So Ki67 I never use. And do I put P16 in everything? Like I actually don't. Only for lesions that don't have a very classic appearance, I will put on, especially for in situ lesions. The question becomes, with some of the newer guidelines, should you put P16 on all your invasive squamous cell carcinomas? And the guidelines would recommend that you do. But of course, that's going to depend on your lab resources and whether you can actually do that. So even though the recommendation will be there, it might be hard for some people to implement. And there is an SCC NOS category if that's the case.
Thank you. The next question is also somewhat similar. So how often do you use the terminology condyloma in vulvar lesions? Do you use it at all, or you just call it all as low grade?
I do call it all as low grade. So again, this is, do you adopt the last guidelines? I know there's some disagreement as to condyloma is completely benign, whereas Elsil has a very low risk of progression to Hcell and more. So I know this is sort of like an entity that people still question. For myself, I will go by the last guidelines. So I will say Elsil, and then I'll put condyloma in brackets. And I think the clinicians like that too, because they're very familiar with condylomas and they like seeing the name. Whereas a lot of clinicians, particularly actually the dermatopathologists, because they're not the terminology is not sort of permeated that genre yet. Is I like to use some of the classical terms, but I'll just put it in brackets just so they have it.
Right. Yeah, thank you. Because I think that is true in other subspecialties as well. Maybe like some of the surgeons or people on the other side are more used to some more accepted terminology. So maybe putting it in the parenthesis is always a good idea.
Mm-hmm.
Right.
Yeah.
I think, here is one last question. For microinvasive carcinomas, when you are in a doubt, so what is your best approach? Do you rely on levels or you do any other stains that you find helpful?
So no stains will help me here. So for microinvasion, so in the context of an HPV associated lesion, there are some histologic features that will help you. And that is that sort of paradoxical maturation or being too pink or too irregular for just a tangentially sectioned reti ridge. For an HPV independent lesion, looking for microinvasion is really, really tricky. And again, it just comes down to levels and instinct, I think, because yeah, I don't think any stains will help in that context.
Right. Thank you so much. I think those are the questions that I could find online on Facebook and on YouTube. And Dr. Hoang, this was an excellent session and we really appreciate it. And you would be happy to know that you had several hundred viewers who tuned in from so many different parts of the world. And I could actually count at least viewers from 30 different countries who joined. And some of the names that I could keep note is Uzbekistan, Peru, Yemen, Turkey, Italy, Brazil, Sudan, Mexico, El Salvador, Zambia, Nepal, Pakistan, Albania, Vietnam, to name a few. So thanks to all our viewers who have defied so many different time zones and attended the lecture. And we really appreciate your support. And if you like the lectures, please don't forget to subscribe to our YouTube channel, that is Patcast. And also you can like and follow our Facebook page by the same name. And we are also on Twitter. You can follow our Twitter handle. And all these lectures can be found archived for on-demand view later on our website, that is pathologicast.com. And you can find the lectures arranged by subspecialty as well. So if you want to look at all the GYN path lectures, you can go to the GYN path section and view these lectures as well. And our next lecture is coming up. That would be next week on March 30th, same time, 9 a.m. Eastern. And this would be on obstetric or perinatal pathology. And we would have Professor Raymond Redlin, who will be joining from Case Western University. And the topic will be placental architecture, maturity, vascular pattern, and dysmorphic features. Hope to see you all then. And thank you all. And thank you again, Dr. Hoang, for this excellent talk for all of us.
Thank you.
Thank you.